Mhm. Okay, good afternoon, everyone. We would like to discuss a case of a 35-year-old alcoholic male who was not being able to sleep due to leg pain. Uh, so this 53-year-old male person, a farmer by background, and belongs to a married nuclear family. He came to us on around June of 2022 uh, with basically two complaints of difficulty falling asleep and alcohol use was there since 10 years. However, he was around abstinent for the last 3 to 6 months, probably. The sleep complaints he described was more of 6 months old, which was acute in onset and continuous in course and progressively worsening. The substance use was around 10 to 20 years and it was insidious in onset, progressively worsening in nature. Uh, as we can see here, that this person had taken his drink around first drink around 20 to 30 years back, and he used to be a occasional drinker previously. However, for the last 3 to 4 years, we can see that it had increased remarkably from about once to twice in a month to about almost regularly for most of the time of the month. I used to consume 1 to 2 quarters of this Indian-made foreign liquor, and he also had some attempts of abstinence. However, he would relapse every time, uh, mostly complaining of sleep difficulty as a cause of relapse. He reported some mild withdrawal symptoms with in form of tremors and headache, nausea. However, it would reverse without any treatment. Uh, a year ago, a patient suffered from jaundice and ascites with deranged liver profile, following which the patient stopped consuming alcohol, but again he was relapsed after about 2 to 3 months. Uh, there's a known case of decompensated chronic liver disease with low-grade esophageal varices with mild portal hypertensive gastropathy. Uh, he also had a past history of melena and jaundice and ascites, as mentioned earlier. There was a history of PCNL done for the left renal calculi in August 2021. There was no significant history of any seizures, loss of consciousness, significant head trauma, or any chronic disorders like diabetes or hypertension or CAD. At admission, the patient was on lacilactone and norfloxacin with the given doses as mentioned here, and tablet thiamine and also fluorodiazepoxide for his sleeping problems. He had a history of recurrent ascitic aspirations in the last 6 months. On examination, the patient had an average built-in average height. There was some amount of icterus which was present, and there was no evidence of any venous prominence in the legs, and there was no evidence of pallor, sinus clubbing, or lymphadenopathy, or any type of pedal edema. The respiratory and the CVS systems were mostly within normal limits. However, parabdominally, we found that he had it was non-tender and no palpable organomegaly. However, dullness at flanks was present, and there was some shifting dullness with fluid thrill was absent. Some shifting dullness was still present. He had normal, he had slightly retracted umbilicus with no visible peristalsis. In the CNS examination, it was more or less within the normal limits. He was a right-handed person, no signs of meningeal irritation. Cranial nerve examination was unremarkable. His motor system was, his bulk tone power was quite normal. His reflexes were within normal limits, and his plantar bilateral flexure. In the attention concentration bit, we find that he had some difficulty in his sustaining of the attention. He could not do digit backward properly, and also there's in serial subtraction he had problems both in 100-7 and 40-3. Again, the name of months he was not able to do backward. Forward he could do, but not the backward bit. There was certain difficulty in that part of sustenance of attention. Memory, we found out for the registration recall part, everything was within his normal socio-educational background, according to his educational background. It was overall intact. The general fund of knowledge was above average, and his arithmetic was again keeping with his educational background. His abstracting abilities was quite within normal limits, both within the proverbial interpretation test and in the similarity of word tests. He had an overall intact judgment when he was asked about certain situations, and based on these answers, we could find out that his social and test judgment were within normal limits. Going to the investigation part, we found that he had a mildly decreased hemoglobin of 9.6, and he also had a certain decrease in the platelet counts, as we can see here. His SGPT SGOT was elevated, and his albumin globulin ratio was also in the reverse range. So we have found some deficits in these parts of his in his investigation. Yeah. So on USG was done, and it had revealed gross ascites with multiple submesenteric lymph nodes with chronic liver parenchymal disease and splenomegaly. So because of his sleeplessness and his use of alcohol, a comorbid diagnosis of insomnia and alcohol use independent pattern was made, and this and combined with a diagnosis of chronic liver disease. Further history revealed that in his when he was asked about his relapse reasons and all what factors would lead to his repeated relapse, so he would tell that the difficulty in falling asleep was the primary cause which would lead him to use of alcohol again and again. And his bedtime was around 11 p.m. His sleep onset latency was about 1.5 to 2 hours. Wake time would be around 5 a.m. with a total sleep time of around 4 hours. He would wake up non-refreshed. He would not be feeling very fresh after the total sleep, which actually a person with a regular sleep routine or a person with a unremarkable sleep routine should feel. And he would have these problems almost in majority parts of the week. So 4 to 5 nights per week, he would be having this problem. Now, as we mentioned earlier, that the alcohol use, the perpetuating factor behind his repeated failure in maintaining abstinence could be somewhat attributed to the chronic insomnia part. Now, however, it was still not totally managed up to this point. He was not responding properly with the chloride oxide of 30 mg per night at the night time, and so when sleep clinic also was included in the picture, what the other differentials we hoped were there were delayed sleep wake phase disorder and restless leg syndrome. So for this thing, we tried to find out that whether there was in any difference between his previous sleeping schedule and his current sleeping schedule. So as I told earlier, the bedtime was almost similar. His sleep onset latency was decreased, but now it was increased, and the wake time was also almost similar to what he had previously and what he is having now. And there was refreshing sleep previously, but now he is not having this refreshing sleep. And in the holidays or in or maybe in the times where he would have the opportunity to get enough sleep, still he would not bind himself to the bed or sleep more. So a possibility of a delayed sleep wake phase was in some extent, to some extent, ruled out in this case. Now, the thing which we were left with was restless leg syndrome. A history of chronic liver disease and non-responding insomnia was to some extent were the pointers which led us to inquire more about this syndrome. So the features we actually unearthed were the urge to move the legs, which in both the legs, and mostly occurring in the nocturnal period at rest. And it would be improved with leg movement. Yeah, if he would also go to the extent of rising up from the bed and walking around and feel partially relieved with his sensations of restlessness. And this was mostly in the nighttime, and rarely in the daytime he had these symptoms. And he would also state that on those days where he had a lot of movement or had a lot of work, to some extent in those nights he would feel relieved, partially relieved about with the respect of these symptoms. So on the more the movement he does, the more relief he gets. And this was present around when inquired further, he told that he remembers 3 to 4 years when he actually started having this problem. And this coincides with the fact or the time period when the alcohol use actually increased in the last 3 to 4 years. An iron profile was ordered, and we found that the ferritin was seriously low. It was 4 nanogram per ml, and an iron concentration was also in the lower range of 50 mcg%. The transferrin saturation has not been given here, but it was also in the lower range, and TIBC was increased. So our diagnosis had to be changed to alcohol use disorder with chronic persistent RLS, and an IRLS score of a very high score of 32 out of 40 was found in this case. With a capsule of pregabalin 150 mg, we started at night time, and within a matter of a week, he showed tremendous improvement, with his RLS score dropping to 12, and he was subjectively much relieved with his sleep, so much so that he told that maybe he would not have to touch alcohol again. And his family members, himself, were very satisfied with the improvement even after just 1 week. So with these very short points, I would like to hand over the baton to Sir Diego for his discussions and from questions from the house.
So we have Dr. Garcia here, and it's a very beautiful case. I mean, it's a case which we see commonly in our OPDs also, in both sleep OPDs as well as in neurology OPDs also. So probably Dr. Garcia can throw some light on this, and please welcome. Thank you so much, sir, for being with us. Probably you can. Are you audible?
Yes. Hello. Can you? I think.
Dr. Garcia, you need to mute yourself. Unmute yourself. Yeah, sorry. You're on mute.
No, I can't. Hold on. Can you hear me now? Can you hear me? No? No. I'm not unmuted.
Yes, sir. You're audible, sir.
Yeah, we can hear you, sir. Now.
We can hear you, sir.
Okay, that's fine.
Yeah, please.
Okay. Okay, well, thank you very much for the invitation, first of all. So from what I see, this is the case of a patient, a subject that is consuming alcohol Well, occasionally, at least initially, and later on in the process of time, that alcohol consume is increased, and it's very much triggered by the fact that he is not being able to fall asleep. Later on, well, the symptoms of RLS go unnoticed for long, and only after the benzodiazepine is being tried and fails to bring an improvement are the questions on RLS brought up. Well, when we retrospectively question the patient, when did your RLS symptoms start? I understand that these symptoms had started 8 years ago. So it is well possible that the cause of these difficulties initiating sleep were due to the existence of RLS. And that these difficulties falling asleep due to RLS were the ones that were being treated by the patient, treated with alcohol. Alcohol was initially being used as a treatment, as a therapy. Later in the process, this patient increased the doses of alcohol and became addicted to it. So a second problem developed, which was alcoholism. And as a result of the chronic alcoholism, later on in the process, a chronic liver disease developed. So the change of events could well have been, it's difficult to reconstruct the past, but it could have well have been that the patient initially developed RLS. As a result of RLS, had difficulties falling asleep. As a result of the difficulties falling asleep developed, well, treated them initially with alcohol, and later on developed the chronic liver disease. This could well have been the chain of events. It is also possible that RLS and the alcohol consumed develop simultaneously without any relation to one another. That's also a possibility. In any case, one of the questions that we have to ask ourselves is, well, there's several questions here. What is RLS? RLS has been already described. It's a neurological disorder that is manifested by difficulties. Well, by difficulties staying quiet, the patient will complain of dysesthesias, of disturbances in the lower part of the legs, and this disturbance will result in a practical impossibility to remain quiet. The disorder happens primarily in the evening and primarily at night. So the main consequence of it is that it is it's a cause for not being able to fall asleep. RLS is very frequently linked to low serum iron levels. Not always. It is thought that the actual cause of RLS is not iron deficiency, at least iron deficiency defined as the presence of low serum iron levels, but that the actual cause of RLS is brain iron deficiency. But we don't have any, at least in this case, we didn't have any way to measure it. This patient, by the way, was having a ferritin value of 4 milligrams per milliliter and a hemoglobin of 9.6, which is an actually low value. Also, I heard that the patient was having low transferrin saturation levels. So in any case, it seems that the patient was suffering from low iron. It's a question that remains to be answered, whether this is a cause or a consequence, because the low ferritin values could as well have developed as a result of the chronic liver disease. It could also have been the other way around, but it is very likely, it's feasible, that the patient started having low iron levels for some other reason that remains to be determined, and that as a result of that, RLS developed. Second, how is it linked to alcohol? The relation, I mean, something we know is that patients with chronic liver disease, I'll go first to the third question. How is it linked to chronic liver disease? It's known that the prevalence of RLS in patients with chronic liver disease is not well known. I mean, the mechanism that leads from chronic liver disease to RLS is not well known. There are speculations on whether the link between the two could be an increased ammonium levels leading to changes in neurotransmitters in the brain. But this is just one among the many possibilities. It's also possible that a storage of iron becomes impaired as a result of the chronic liver disease, and that ultimately will lead to brain iron sufficiency. That's another possibility. How is it linked to alcohol? Well, we cannot really say that alcohol per se leads to RLS. Although, I mean, this is frequently being described, but there are no good data showing that alcohol consumption per se leads to RLS. However, if alcohol consumption leads to chronic liver disease, then yes, RLS becomes more likely. In many cases, alcohol is being used as a treatment for RLS. So it's the easiest thing to have at hand in order to achieve to treat the sleeplessness that accompanies RLS. How does the treatment work? Well, we're talking here about the treatment for RLS. Before we go into how does the treatment for RLS work, we have to say a few words on what causes RLS. There is still a controversy on what is the actual cause of RLS, but the most likely, the most current theory about the cause of RLS is that RLS results ultimately out of brain iron deficiency. And the brain iron deficiency leads to an increased glutamatergic activity in the corticostriatal pathways in the brain. And that produces indirectly the RLS symptoms, both the hyperarousal, which leads to not being able to sleep, and that will also lead to the dysesthesias, the discomfort in the legs, the focal akathisia, I mean the restlessness in the lower part of the legs, and also to the periodic leg movements. Periodic leg movements, which are like periodic jerks that occur while the patient is asleep. These are a typical feature of RLS. It's not specific, but it's very common in RLS. So how does the treatment work? The treatment that was used in this case was pregabalin, 150 milligrams of pregabalin. Pregabalin, similar to gabapentin, what it ultimately does is it will reduce the release of glutamate in the corticostriatal pathways. And because the cause for RLS is increased glutamatergic function in the corticostriatal pathways, pregabalin, as much as other anti-glutamatergic drugs, for example, gabapentin, also perampanel, some anticonvulsants do the same thing. What they ultimately will do is they will reduce glutamatergic release in the corticostriatal pathways. Other drugs that can be used for RLS are the dopamine agonists. These drugs, dopamine agonists, do exactly the same thing. The corticostriatal pathways contain dopaminergic D2 and D4 receptors, and the stimulation of these receptors by the dopamine agonist has have an inhibiting effect upon the glutamatergic pathways. Another treatment, particularly in this case, could well be iron administration, intravenous iron administrations. The main challenges to the treatment of RLS is that, I mean, as I mentioned before, there are two possibilities of how to treat it. First of all, iron levels have to be normalized. As long as there are reduced brain iron levels, RLS will continue, and we will need a pharmacological therapy. So iron administration is going to be one of the main features of the treatment for RLS, but it becomes a challenge to bring that iron into the brain. What we need to do in the meantime is to reduce this glutamatergic function. So we have two types of pharmacological treatments as a symptomatic treatment. One of them would be pregabalin and gabapentin. Pregabalin and gabapentin have some side effects. They produce sleepiness during the day. Usually, this is not such a big problem because normally these drugs are administered at night. But they can also produce dizziness in the early morning. They can produce liquid retention, etc. And their efficacy to treat the RLS symptoms, we have to say that too, is moderate. Much more powerful are drugs like dopamine agonist, which I mentioned also before. Out of the dopamine agonist, we have a drug like pramipexole. Pramipexole is not a drug that we could use in this case because its metabolism, it's fundamentally going to be a hepatic metabolism. So it will be metabolized in the liver. And in this case, with a chronic liver disease, we shouldn't use pramipexole. A feasible alternative would be ropinirole, which is another D2, D3, which in contrast to pramipexole is metabolized in the kidney. And that would have been a very, very effective alternative to pregabalin. In this case, I have nothing to say because pregabalin worked well, it seemed. So there is no problem with, there wouldn't be any reason to change it to ropinirole. A third alternative would have been rotigotine, the rotigotine patch. I'm not sure that this drug is available in India. It's not in every country. In some countries, in Europe, it's very common. It's a patch that you put your skin, and it's also a drug with a very similar mechanism of action to ropinirole or pramipexole. It's also metabolized mainly through the liver. What are the challenges to the treatment, to the dopaminergic treatment? Dopaminergics are very effective over the short term and are very frequently being used for a so-called therapeutic trial. It's a way of making sure, it's very common, it's a way of making sure that the patient, that what we're dealing with is RLS and not something else. It's very common. to prescribe a 1, 2, 3 weeks treatment with a dopamine agonist at a low dose. However, over the long term, I mean, these drugs can also be used over the long term, not just as a therapy, not just for a therapeutic trial. Over the long term, the main problem of these drugs is that that their efficacy wears off, so that they develop tolerance to these drugs. Initially, it will look as if you would achieve, with the same dose of the drug, less and less and less effect. At some point, it will develop further, and what you will see is that symptoms are not only, you will see that not only that the effect of the drug is getting lower and lower, but that the drug by itself is making symptoms worse and worse and worse, so that at some point, these symptoms, while on treatment with a dopamine agonist, become worse than they were before treatment had been initiated. So in other words, you're making the disease worse with the treatment, with the dopaminergic treatment. And this is the main challenge of dopaminergic drugs over the long term. In many cases, you won't be able to restore in full the brain iron stores. And as a result of that, in many cases, you won't be able to restore them. Why? Because there will be a problem transporting, you can increase the serum iron stores in as much as you want. However, there will be a problem in transporting the serum iron into brain iron, into the brain stores. We have the blood-brain barrier, and the transportation of iron across the blood-brain barrier is selective. It's not just a passive osmotic one. So you will find ultimately in many cases, not always, but in many cases, you might find a barrier that prevents you from normalizing the situation. And what is the consequence of that? That you will have to treat the patient with pharmacological treatment. You will have to perform a symptomatic treatment lifelong. And the consequence of that is that you might, if you are using dopaminergic drugs, the chances of augmentation developing are very high. There are two main factors. A number of factors have been described in the literature leading to dopaminergic augmentation. But the two more consistent ones are, first of all, dose. The higher the dose of the dopamine agonist, the more likely augmentation is going to occur, to develop. So dose is one of the main players here. And the second one is duration of treatment. The longer the treatment, the longer the duration of the treatment, the more likely augmentation is likely to occur. If we're speaking here about a disorder that in many cases, at least in the severe cases, in many cases it will be lifelong, so the chances of augmentation to occur are going to be quite high. So this is the main challenge to long-term treatment. There are other problems also with dopaminergic drugs. The other one that remains to be mentioned is impulse control disorder. Just to make it, to explain it briefly, the drugs, the dopaminergic drugs, this is not something that will occur with pregabalin, which was used in this case, by the way. But dopaminergic drugs, had these drugs been used, could be leading to impulse control disorder. This is manifested by, just to simplify it, by an occurrence of new impulsive behavior. That impulsive behavior can occur in the form of obsessive compulsive symptoms, increased buying, increased gambling, and all these occurs in patients that previously to the dopaminergic treatment never had any problem with that. If there was already a problem with that, then it might be reinforced. It's even worse. But whenever you administer a dopaminergic drug, you should also warn the patient about this impulse control disorder. There's also an increased sexual behavior. Why is that? I mean, these are dopaminergic drugs, and dopamine are very much involved in the neurobiology of impulse control, and also in the neurobiology on reward in addiction. So yeah, this would be the main challenges to the treatment in this case. In general, I mean, here in this case, we have the particularity of having also a chronic liver disease, and that will modify our treatment choices at the same time. As I mentioned before, pramipexole shouldn't be used, but ropinirole, pregabalin, or gabapentin are drugs that could be used in this case. The other lesson to be learned from this case is why, RLS is a common disorder. It's much more common in the West than in Asian countries, because there are some ethnical factors linked to RLS probably. But still, the prevalence in Asian countries, the Japanese have investigated it particularly well. It ranges between 1% and 4% of the adult population. However, most of these patients are not being diagnosed. So there is a lack of awareness of RLS among the medical profession. Well, we know as doctors that whatever you don't have in mind, you don't ask. It does not exist for you. Your patients won't have it, in other words, somehow. No? And there is a need of much more education on RLS. In this case, the disorder came up quite late, but it would be and could have been treated years before. In fact, yeah. But this is not rare. This is a case that shows how much education on RLS is necessary. It's a disorder. It's a neurological disorder that is much more common than many other neurological disorders.
Thank you, Dr. Diego, for answering some of these questions in such a beautiful way. If you have any questions.
If you have any questions from the audience, probably Dr. Garcia will be happy to answer. And
I was wondering if we should have done vitamin B12 level in this patient, considering the fact that the patient was alcoholic and chances of B12 are deficiency are there in that patient. Plus B12 may cause, what is your take on that B12 in such kind of a patient? Vitamin B12. Related B12, yeah.
Do you want me to answer that? I'm not sure who is supposed to answer the questions. Do you want me
you, yes.
Okay. Thank you.
Yeah.
Thank you. So B12, I mean, we don't have any data that B12, at least we don't have any reliable data showing that B12 might be involved in the cause of RLS. However, I agree completely with you. There might be, B12 would be important for the comorbidities of RLS. B12 might be involved in neurological disease. It might also be it's very common in chronic liver disease, in alcoholic chronic liver disease, and it's also a cause of polyneuropathy, which frequently accompanies, goes along with RLS. So we should definitely, the answer is we should have looked for B12 as well. And also for a folic acid.
Dr. Garcia, I do have a question for you.
Yeah.
Actually, we have a question from one audience. Is there any role of folate in RLS? So
not directly. The same answer as before. We always measure it because okay, you will see. I mean, it's very frequently being looked at, but for comorbidities of RLS. Since you have to look for iron, let's look at disorders that are very related, and folate is very frequently involved in polyneuropathy. So since polyneuropathy is very commonly associated to RLS, we should also try to look for folate. Another substance, just anticipate a similar question, that is frequently related to RLS is vitamin D. Vitamin D. A lack of vitamin D could lead to RLS. It has not been demonstrated ever. I mean, many RLS patients have a decreased vitamin D, but the causal role between the two is far from clear. There is no single report showing that treatment of vitamin D, or let's say, there is not a single report showing that treatment of RLS with vitamin D improves the RLS.
thank you, Dr. Garcia, for your beautiful talk on this topic. In fact, from the neurology point of view, I would say that probably we should rule out small fiber neuropathy, alcoholic-related small fiber neuropathy in this patient. That could also present with dysesthesia symptoms which this patient had, and RLS could have been an accompaniment of that neuropathy, because yes, it cannot be diagnosed. Reflexes will be normal in a small fiber neuropathy, and it cannot be diagnosed on routine investigations also. So we must also, I mean, we have seen some patients as pointed out by the audience, B12 deficiency also was related. I mean, we have not done a research on that, but somehow we have seen that B12 supplementation also helps patients in RLS patients, in whom we have not given ropinerol or pregabalin, any of them. And yes, we agree with you completely that we have used ropinerol for diagnosis of RLS, and is very frequently used. Thank you so much. Thank you so much for spending time for this talk.
May I say a last thing? May I say something more? One
Yes,
last thing.
why not? Why not?
Small fiber neuropathy. Sure. The problem is that small fiber neuropathy, well, it's a diagnosis that is not easy to make. We know that it exists, but we don't know how to measure it. I mean, we can do thermal tests.
Yes,
which are,
sympathetic response we perform in our department, and also thermal COSAT. We do it.
Good, and we can also biopsy. But the thing is that we could do something much simpler than that, because neither of these tests are definite for a small fiber neuropathy. At the end, there will be also a doubt whether we missed the target. We could do something much simpler than that. See whether this patient responds to ropinerol or not. Ropinerol is a pure dopaminergic drug. In a patient with pure small fiber neuropathy, or in a patient with a polyneuropathy, ropinerol will do nothing, will have no effect. While pregabalin, which was the drug that was chosen, will lead to an improvement, as it has done. So the response to pregabalin leaves the window open on whether this is actually RLS or whether it could also be a small fiber neuropathy. If we want to differentiate between the two, the easiest thing to do would be to just to try one for 1 week ropinirole.
Yes, yes, agreed. Thank you so much. Thank you so much for being with us. Now we close the session, and
Thank you, Dr. Diego, for a very enlightening session.
Thank you very much. Thank you for the invitation to all of you. It's a pleasure always to be in India. Thank you. Bye. Bye-bye.
Thank you, sir. Now I would request